Welcome to A to Z Nursing Vlogs. Here we have another video on the Chikungunya virus. Let's dive into the video. What is Chikungunya virus? Chikungunya is a self-remitting febrile viral disease that has been associated with frequent outbreaks in tropical countries of Africa, Europe, America, and Southeast Asia. Chikungunya virus is an insect-borne viral illness that causes sudden onset fever, arthralgia, and rashes. It is transmitted to humans through day-biting mosquitoes that belong to the Aedes genus. The term chikungunya often refers to both the virus chickpea and the illness or fever chick-F caused by this virus. Further, it was derived from the African dialect Swahili or Makonde and translates as to be bent over in Congo. It is referred to as buka buka, which means broken broken. These terms refer to the stooped over posture exhibited by individuals with the disease as a consequence of severe chronic incapacitating arthralgias. Humans are the primary host of the chikungunya virus during epidemic periods. The causes of chikungunya. Chikungunya virus is an alpha virus that belongs to the Togaviridae family. It is single-stranded RNA virus and is approximately 11.8 kb long with a capsid and a phospholipid envelope. Chikungunya virus is transmitted to humans through day-biting mosquitoes that belong to the Aedes genus. Being an arbovirus, the virus is maintained in the environment between humans or other animals and mosquitoes. Humans serve as major reservoirs during epidemics. During inter-epidemic visits in Africa, the virus is thought to be maintained in an epizootic cycle that involves vertebrates such as monkeys, rodents, and birds. In Africa, the virus is maintained in a sylvatic cycle among wild primates, monkeys, and wild Aedes mosquito, which is Aedes furcifer, Aedes taylori, Aedes luteocephalus, Aedes africanus, and Aedes newafricanus. In Asia, the virus is maintained in an urban cycle involving A. aegypti mosquitoes and humans. The clinical manifestations of chikungunya virus. Symptoms usually begin 3 to 7 days after being bitten by an infected mosquito. Fever. One of the most common symptoms is high-grade fever up to 105 degrees Fahrenheit. Arthralgia. The arthralgias are usually polyarticular and migratory and frequently involve the small joints of the hands, wrist, and ankle, with lesser involvement of the large joints such as the knee or shoulder with associated arthritis. Joint pain is worse in the morning, gradually improving with slow exercise and movement but exacerbated by strenuous exercises. Cutaneous manifestations. Individuals with chikungunya fever frequently present with a flushed appearance involving the face and trunk, followed by a diffuse erythematous maculopapular rashes of the trunk and extremities, sometimes involving the palms and soles. The rash gradually fades, may evolve into petechiae, urticaria, xerosis, or hypermelanosis, or resolves with desquamation. Neurological manifestations. In the acute phase of the illness, which was reported during the outbreak in the Indian Ocean in the year 2005-2006, 23 patients presented with neurological symptoms associated with abnormal CSF tests and positive CSF immunoglobulin M or reverse transcriptase polymerase chain reaction for chikungunya virus. Others rare presentations include severe rheumatoid arthritis, neuroretinitis, uveitis, hearing loss, myocarditis, and cardiomyopathy. The assessment and diagnostic findings. Number 1. Serological testing. Chikungunya virus specific IgM antibodies usually appear upon cessation of viremia, usually by day 5 to 7 into the illness, and stay positive for 3 to 6 months. Immunoglobulin G neutralizing antibodies appear after 7 to 10 days and may persist for several months. These antibodies are detected with an enzyme-linked immunoassay ELISA test that is available through the CDC and several state health departments. Number 2. Viral culture. Chikungunya virus may be isolated in culture within the first 3 days of illness during the period of active viremia by inoculation of blood into mice or mosquitoes. Culture-based detection is also available through the CDC. Molecular diagnostics. RT-PCR has been standardized using both structural and non-structural domains of the chikungunya virus genome and is available through the CDC. These are the assessment and diagnostic finding methods. Medical management. There is no specific antiviral therapy or vaccine for chikungunya virus infection. Treatment is focused on relieving the symptoms. To relieve the joint pain and fever, treatment is for symptoms and can include rest, fluids, and use of non-steroidal anti-inflammatory drugs, which are the NSAIDs, to relieve the acute pain and fever. Monitor glucose levels. Poor glycemic control in patients with diabetes who have chikungunya infection has been reported. It is important to monitor the blood glucose closely in these patients. Conservative treatment. Conservative treatment includes management of electrolytes. Nursing management. Nursing management is a step-by-step process which begins with the nursing assessment. To begin with the history collection, the chikungunya fever is an acute febrile illness with an incubation period of 3 to 7 days. It affects all the age groups and both sexes equally, with an attack rate of 40 to 85%. Then comes the physical examination. Clinical examination reveals high-grade fevers, pharyngitis, conjunctival suffusion, conjunctivitis, and photophobia. Cervical or generalized lymphadenopathy has also been reported in rare cases. Nursing diagnosis. Based on the assessment data, the following are some of the nursing diagnoses for patients with chikungunya. They are hypothermia related to increase in metabolic demand, deficient fluid volume related to dehydration, pain related to joint inflammation, and impaired skin integrity related to cutaneous manifestations. Nursing care planning and goals. The major nursing care planning goals in a patient with chikungunya virus includes: patient will improve the body temperature, patient will restore an adequate amount of fluid volume, patient will experience relief from pain, and the patient will show an improvement of the integrity of the skin. Nursing interventions. To improve the body temperature, the nurse has to eliminate excess clothing and covers, give antipyretic medications as prescribed, perform tepid sponge bath, modify cooling measures based on the patient's physical response. To restore the adequate amount of fluid volume, the nurse can assess the skin turgor and oral mucous membranes for signs of dehydration, assess the color and amount of urine, and report urine output less than 30 ml per hour for 2 consecutive hours. The nurse can urge the patient to drink the prescribed amount of fluid and administer parenteral fluids as prescribed. Relief from pain. The nurse can acknowledge reports of pain immediately, provide rest periods to promote relief, sleep, and relaxation, provide analgesics as ordered, evaluating the effectiveness and inspecting for any signs and symptoms of adverse effects will help. To improve the integrity of the skin, the nurse can monitor the sites of impaired tissue integrity at least once daily for color changes, redness, swelling, warmth, pain, or other signs of infection. Provide tissue care as needed. Tell the patient to avoid rubbing and scratching. The nurse can provide gloves or clip the nails if necessary. Administer antibiotics as ordered. The nursing process is completed by evaluating the improved body temperature, the restored adequate amount of fluid volume, relief from pain, and improved integrity of the skin. If the contents of this video are informative, like and share the video, subscribe the channel and click on the bell icon for more updates. Thanks for watching.